Now that we're set up, I'd like to introduce our moderator, David Michaels, an epidemiologist and professor at the George Washington University School of Public Health. Dr. Michaels brings deep understanding of the safety challenges facing workers, having served as the top workplace health and safety official for the Obama administration and is the longest-serving Assistant Secretary and Administrator of the Occupational Safety and Health Administration at the Department of Labor. Earlier this week, President-elect Joe Biden added him to the Transition COVID-19 Advisory Board, where he will work to ensure that workplace safety has a voice on the task force. Thank you for being here, Dr. Michaels.
I'd like to begin by thanking our three host unions for today's event. The American Federation of Teachers is 1.7 million members working to serve our communities in pre-K through 12 education, healthcare, public service, and higher education. Through the pandemic, AFT members have cared for the sick, conducted COVID testing and contact tracing, provided food for members in hundreds of different occupations, from first responders to nurses to corrections officers, childcare providers to sanitation workers. Oh, sorry, I was reading that wrong. I'm sorry. They conducted COVID testing and contact tracing, provide food to hungry families, work to teach and support our nation's children and families through various types of learning. In a time where federal leadership has been lacking, AFT members continue to care, fight, and show up to ensure our communities keep going. AFSCME, the American Federation of State, County, and Municipal Employee members, provide the vital services that make America happen. They maintain our roads, care for the sick and elderly, make our schools good places to learn, keep our community safe, and much, much more. With members in hundreds of different occupations, from first responders to nurses to corrections officers, childcare providers to sanitation workers, AFSCME advocates for fairness in the workplace, excellence in public service, and prosperity and opportunity for all working families. And our third host, SEIU, the Service Employees International Union, is a diverse union of more than 2 million members in healthcare, public and property services. SEIU members have been in the front lines as essential workers, serving and caring for the public, providing vital medical care, and fighting for all working people. SEIU members have cared for those with COVID-19, have seen family members sickened, and have gotten sick and tragically died themselves. This vaccine could have had incredible consequences for their lives, and many of them fall into the early categories of distribution. And so I'm very pleased to be moderating this important discussion on the COVID-19 vaccine. And I'm moderating this in my personal capacity, not in my role with the Biden-Harris Transition Advisory Board on COVID-19. So this is a really exciting time in the development of the COVID vaccine. It's an important time, not just for the development though, but also for transparency and for understanding the safety, efficacy, and equitable distribution that has to occur when this vaccine is available. Each and every one of us will need to make our own individual decisions regarding vaccination based on the best information available. Tonight's virtual town hall event is an opportunity for all of you to hear directly from and have a dialogue with some of the nation's leading experts on vaccines, the people who are making the decisions for the government for the entire country. And so we're really fortunate tonight to have them with us. Three people, experts in the field of immunization, development, safety, infrastructure, and health equity around this vaccine. So our three panelists, the first will be Dr. Peter Marks. He's the director of the Center for Biologics Evaluation and Research at the US Food and Drug Administration. That's the agency responsible for reviewing the safety and efficacy of the COVID vaccine and all the candidates. You've no doubt read all about what they're doing right now, considering the vaccines that have been presented to them. Second, we're going to have Dr. Nancy Messonnier, the director of the National Center for Immunization and Respiratory Disease at the Centers for Disease Control and Prevention, the CDC. Her agency is involved in efforts to prioritize which groups should receive the COVID-19 when and in what order, and is also responsible for coordinating with state and local public health authorities on vaccine distribution and administration plans. And our third speaker, Dr. Patricia Whitley Williams, is from the Rutgers Robert Wood Johnson Medical School, where she's a renowned infectious disease specialist and a very respected voice on healthcare equity issues. So we're really covering three really important topics today. So first, I want to thank all three panelists for joining us here today and for their willingness to take time from their incredibly busy schedules to answer questions from union members across the country. We all know how important it is right now to be sharing information and answering questions around the development and approval of this vaccine, and the process that will be deciding who's going to get the vaccine, in what time framework, in what order, and what we can all expect in the coming days, weeks, and months ahead. So I'm asking each speaker to open up with some brief remarks, and then we'll get to the questions that many of you have submitted. But first, before we dive into that, I want to tell you why I think this is such an important issue, why I'm here. And, COVID-19 is a worker safety crisis. Hundreds of thousands of healthcare workers have been sickened, and thousands have been killed by the virus. And, it's not only healthcare workers. Some of us can work from home, but so many workers can't. These are the workers who make sure food is produced and so we can feed our families. The workers who take care of our seniors, who teach school, who drive our buses. They do so much essential work and they have no choice but to go to work, and they're at risk for exposure to this virus. As you heard, I ran OSHA for President Obama. Most of my work's been in worker safety and health. I've spent the last 8 months trying to figure out how to make sure workers are safe. I'm also a proud former member of AFT, Local 2334, the Professional Staff Congress. So I know that unions play a central role in protecting the safety and health of working people. If you don't have a union, you have far less ability to make sure your work is safe. Now, during the course of my entire career, I've worked with your unions to ensure that the health and safety of the women and men that support the American economy and our public health come first. The COVID-19 crisis is the greatest public health challenge this country has faced in many decades. If workers are not safe, we won't be able to get the economy working for everyone, which is the goal of the incoming administration and the goal of everyone at this town hall meeting today. And the vaccines that are about to become available can play a very important role in preventing that deadly disease and making this economy, making the country work again. So as union leaders, you have a key role to play, making sure all workers are safe, and we've designed this program for you. So first, I'm going to turn this over to Dr. Peter Marks. Dr. Marks is director of the Center for Biologics Evaluation and Research at the FDA. That center is responsible for assuring the safety and effectiveness of biological products, including vaccines, and also provides oversight throughout the entire life cycle of the vaccines. So Dr. Marks, if you would, please walk us through what the FDA review process, clinical trials, and what you're looking for in terms of safety and efficacy of a vaccine in order to approve it so we can all take it.
Right. So first of all, thank you everyone who's joining, and thanks for all that you do every day. So the review process at FDA is put in place to ensure that any vaccine that is ultimately made available is going to be safe and effective. These vaccines are going through a development process in which they're being studied in a large number of people in order to understand that they're both safe and effective. Now, normally that takes a course of several years, and here that's being condensed down in time, but by using a number of techniques, we are trying to get the same type of information that we need to feel very confident that when we finally make a vaccine available, it has the type of safety and effectiveness that we would like to see from vaccines given to healthy people. So the size of these trials is on the scale of about 30,000 to 44,000 people for the two vaccines that are coming up front, the Pfizer vaccine and the Moderna vaccine. And those are relatively large randomized trials. They've been very well designed to try to give us an answer and to look at safety events. Those manufacturers have submitted them to us as part of something called emergency use authorization requests. And that's a little bit of a term that may be foreign to some. Most of our biologic products go through a process, such as vaccines, they go through a process in which they get a biologics license. And a biologics license means that we've determined those products to be safe and effective to a certain standard, which means they have to have substantial evidence. In other words, there has to be a really good evidence that they are effective, and they have to be safe. Now, this emergency use authorization standard was put in place after the terrorist attacks of 9/11 to allow us to deploy drugs or biologics or to use devices in the event of a natural disaster or a man-made disaster. And we'll consider this viral spread a natural disaster-like thing. And what that allows us to do is use products that are not necessarily approved to our normal standard of approval, but to a somewhat lower standard in order to make available products to the public in need. Now, for people who are sick with disease, using that somewhat lower standard of things that might be effective rather than are almost certainly effective may make sense. But what we've decided for these vaccines is that they are going to have to be more like the products that we normally approve, more like products that have a biologics license application. They will have substantial evidence of effectiveness. To just kind of finish up what I'm trying to say here, what I'm saying is that the emergency use authorization is a floor of what of a minimum amount of effectiveness that a product would have to have at this time to allow us to use it. And there are plenty of drugs that have been used at this point in that way. But for a vaccine, we are going to have use something that's much higher than that. So if you consider that the floor, this is going to be much closer to the ceiling. The ceiling could be considered analogous to a licensed biologic process. We're going to be closer to the ceiling, like a chandelier hanging off the ceiling with these products, in that they're going to have to show the kind of safety and effectiveness that will make us feel comfortable that those products are safe and effective enough for us to take ourselves, for us to have our families take, and for us to see people across the country take. So I'll stop there and I'll look forward to questions later on.
Thank you, Dr. Marks. Next, I'm very pleased to welcome Dr. Nancy Messonnier, who's the director of the National Center for Immunization and Respiratory Diseases. That's part of CDC. Since she began her public health career in 1995 as an epidemic intelligence service officer, she's been focused on understanding and preventing infectious diseases, especially the vaccine preventable diseases. Dr. Messonnier, can you share with us an overview of the process taking place right now to determine the recommendations around these vaccines, including which populations should receive the vaccine first, how the distribution process might be phased in over time, and can you speak to how the CDC is planning to communicate this process with healthcare providers, with priority populations, with us? That's what we really need to know. So let me turn over to you.
Thank you, Dr. Michaels. And it's a lot to cover in 5 minutes, but I'll try to take a good start. Thanks you all for the opportunity to talk today about this really important issue. You know, when I think about this pandemic, I like to say that part of our job at CDC is to prepare for the expected, the unexpected, and the unimaginable. And even though this is unimaginable, it's actually built off of existing systems that we have been working on for years. If I could have just the first slides. One of the things that we have at CDC is a system that has checks and balances, and that's across the federal government. And it's really to ensure that our vaccine supply is safe and effective, and that we have checks and balances to make sure that we're all basically looking at it independently. So in addition to the process that Dr. Marks described, there's a process at CDC that's driven by our ACIP, our Advisory Committee on Immunization Practices. ACIP is a committee that's been around for many years. It consists of 15 experts who are voting members, and they're selected based on their expertise in vaccinology and immunology and medicine and public health. We also have one member of the committee who's actually a consumer representative to provide perspective on the social and community aspects of vaccination. It's important for you to realize that these members are vetted for conflict of interest to really make sure that they can truly be independent. And in addition, there are 30 non-voting members that represent professional organizations. They're the ones that offer the perspectives of their groups because their groups are the ones that are required to implement the recommendations. We stood up an ACIP working group to think about COVID vaccines in the spring, and the full ACIP has been meeting since June. And one of our principles is those meetings take place in plain air. They're televised so that anyone can watch and see what the deliberations are. ACIP has two tasks here. One is after FDA authorizes the vaccine for an EUA, ACIP will make recommendations for use of the vaccine. And so ACIP has been thinking since June about the disease, the epidemiology, and about the vaccine, what we know about safety and effectiveness. And we expect that deliberation to really come forward in December, again, after the EUA. But in addition, ACIP also has the task of thinking about prioritization. And what we know about this vaccine is we expect the initial doses to be available in December, but based on what we know from Operation Warp Speed, we expect to be in a setting of limited supply for several months. And ACIP has therefore been thinking since June about how you'd prioritize the vaccine. They published an ethical framework that basically talks about the importance of maximizing benefits and minimizing harm, promoting justice, mitigating health inequities, and promoting transparency. And in all their deliberations around prioritization, they really make sure that they think about each of these principles. Next slide. So yesterday, fresh off the presses, ACIP met to vote on the initial priority groups for vaccination. So this is what we're recommending for the first 30 days, basically when there is a very limited supply of vaccine. ACIP is recommending that the first doses of vaccine go to healthcare personnel and residents of long-term care facilities. And specifically, even within those groups, ACIP and CDC is offering additional guidance in terms of how you sub-prioritize. For example, among healthcare workers, there are some healthcare workers who are at higher risk. And among residents of long-term care facilities, it's actually the residents of skilled nursing facilities are at higher risk. So we call those groups 1A, and below you'll see the general framework that ACIP is using. The jurisdictions, that is the states and local health departments that have been planning and preparing for vaccination, are set to order their initial doses of COVID-19 vaccine based on the ACIP recommendations. That will all be in by Friday. And the idea is that we'll have consistent allocation nationwide with the focus on healthcare personnel and long-term care facilities as a way to ensure a smooth launch and subsequent distribution and administration of these vaccines. These vaccines are poised to go out into the communities within 24 hours after the EUA, as promised by Operation Warp Speed, and we expect implementation of the vaccines to be really rapidly afterwards. But remember, this is those initial doses of vaccine. We expect it to be somewhere around 40 million doses in December, which means basically you can vaccinate 20 million, perhaps a little less people. So it's a very limited number of people that will get it in this initial phase. Next slide. There's a lot of focus on that initial rollout, but we also really need to be thinking about the additional sequences after that. And this lays out those sequences in a series of bars. That is, ACIP will continue to have deliberations, and we expect a vote on this issue at the December meeting. But their current framework, dependent, of course, on seeing the data on safety and effectiveness, which we haven't seen yet, but their general framework is that after healthcare workers and long-term care facility residents, the next vaccine should go to essential workers, and then the vaccine after that to adults with high-risk medical conditions and older adults. But you also should see that these bars overlap. And the idea here is that these are not set phases, that we're going to have to really move rapidly from one phase to the next. In terms of essential workers, part of the issue is that each state is unique, and that the groups that will be considered essential workers, for example, in Maine is likely to be different than Arizona. But we are working to start planning now for those essential workers. And also, we really think it's critical that jurisdictions start planning beyond just these groups to make sure that they can ensure easy access to vaccine in, for example, those with limited access to vaccination, like the rural populations and communities of color and tribal nations. We're really asking the jurisdictions now to form those partnerships to make sure that we can make vaccine easily accessible to every corner of the community, but really also so that we can work now to build those partnerships so that we can ensure that there is communication and transparency so that key messages can really go out throughout the entire community. I'll stop there and look forward to your questions.
Terrific. So our last speaker, before we get to questions, I'm really pleased to introduce Dr. Patricia Whitley Williams to the conversation. Dr. Whitley Williams is a professor of pediatrics, and she's the chief of the Division of Pediatric Allergy, Immunology, and Infectious Diseases, and the Associate Dean of Inclusion and Diversity at Rutgers Robert Wood Johnson Medical School in New Jersey. Dr. Whitley Williams is also the president of the board for the National Foundation for Infectious Diseases, and very importantly, she serves as the National Medical Association liaison to the advisory committee to ACIP, Advisory Committee on Immunization Practices. The National Medical Association is the leading voice of Black physicians. The COVID-19 pandemic has shed new light on long-standing disparities in health outcomes among African Americans and other minority populations, and has underscored the critical need to examine and address systematic barriers, concerns, and hesitancies about vaccines. So Dr. Whitley Williams, can you speak to a few of the challenges we face? Talk about your work on the advisory committee and your vision on what's needed to reach communities that have been long overlooked and underserved by our healthcare system. And also, if you can, what we need to do to educate the public and healthcare professionals to meet these needs.
Absolutely. Thank you so much. I thank you for the invitation to address this group. It is a pleasure. This is it's interesting. Once you have a vaccine, if the vaccine does not make it into the person's arm, then what good is it? So we have a lot of work to do, and actually a lot of work has been going on. So thank you, Dr. Michaels. I am thrilled to talk about these issues. So first, I'm going to talk about the importance of educating providers, the physicians, and other healthcare providers who will be delivering the vaccine to persons. And just to remind everybody, hundreds of millions of vaccines are given every year in the US without any problem. Billions of vaccines are given each year in the world. I'm a pediatrician, so we are used to vaccinating persons, unlike maybe our adult colleagues. So we know we have to work with our provider organizations and all physicians in terms of really carrying out this vaccination. Now, vaccines, I don't have to remind you, are important in preventing diseases, mostly infectious diseases, but also cancers. We know that vaccines are safe. And if I can say, just by observing and participating in the ACIP meetings, that the new COVID vaccines are being studied, perhaps even under more scrutiny than I have ever witnessed before. I think one thing it's very important that the providers realize that vaccines are safe. And there are many mechanisms that have been developed, that have been in existence, that are going to be used to track people who have been vaccinated to ensure that any adverse event that might come up would be recognized. Adult providers are not used to giving vaccines like our pediatricians and family physicians. So we understand, and this is already ongoing, that there is education of these providers, multiple health alerts, multiple webinars such as this, medical education courses being conducted online. Also training physicians how to put in place what we call reminders and recalls so they can follow and remind unvaccinated patients as well as patients. There are the COVID vaccines, some of them require 2 doses. So we're going to have to bring patients back in a month to receive that 2nd dose. So it's important that physicians have in place a reminder, what we call a reminder and recall system, so we don't lose any patients in terms of completing vaccination. Also, it's important in communication that the physician provides to their patients or to their parents, that there is a way to have this discussion about immunizations and certainly to address any concerns. It's important, and there have already been preparation for distribution of posters and pamphlets, not only in English, but in other languages. And this would be important in terms of physicians being able to place these in their offices and in medical facilities, in clinics, so that patients, while they're waiting, can also continue to be educated. Very important to ensure physicians about the vaccine supply. That's important in terms of building confidence in providers. We know there is going to be a limited supply initially with the COVID-19 vaccines, but we also know that eventually there will be enough to go around. So it's very important, and also to keep physicians knowledgeable and keep them abreast about what's going on with the vaccine supply and as new vaccines are being approved. And you've heard a little bit about that process. You also have heard that I'm a member of the National Medical Association. There are many other provider organizations that are already working with their membership to educate physicians about the COVID-19 vaccine. The second piece is, of course, to educate the public. And that is so important. As you've heard, we're going to be teaching physicians in terms of communicating with their patients. Actually, the CDC is coming out with a whole program called Vaccinate with Confidence. Again, this is to engage and strengthen public trust in vaccines, also to engage the trust and confidence in providers as well. Studies have shown that patients will ask their providers whether they should take a certain medication or whether they should take the vaccine. And in this case, we know that patients are already asking their physicians, their healthcare providers, should I take the COVID-19 vaccine? And along with that, with this confidence, we know there are 3 things we probably need to do. One is protect communities. All communities obviously make up our public health, and we are concerned about all communities. But we also understand that the COVID-19 pandemic has been particularly harsh to certain persons in communities of color, whether that's due to comorbidities, other chronic illnesses that exist in persons in communities of color. But what this pandemic has shown us that communities of color have been disproportionately affected. And also we know that many persons from communities of color make up the essential workforce, from workers from service industries who support the infrastructure. So it is important to protect these communities, but also to engage these communities. This is going to be done through new partnerships. It'll be important to empower all families. This is, again, to create a trust in vaccines. Again, a vaccine is not good if it's going to sit on the shelf. It has to go into the arm of the patient. We want to make sure that this conversation continues, and it's not just doctors and parents, but it also includes nurses and pharmacists. Pharmacists are going to be engaged in administering the COVID-19 vaccine to certain members of the community. So this is very important to continue this conversation. I like to think about communicating as having 3 things. 1, there's a message that needs to be given. 2, it's important for the person giving the message to know how to do that. And 3, you have to consider the person who's receiving the message. So great detail is being paid to this area of communications. So empower families that they understand what's going on and that they become part of this process, and making sure that people who certainly are at risk are protected, and that eventually anybody who wants the COVID-19 vaccine will have access. And then the third thing is to stop myths. Well, this not only exists about the COVID-19 vaccine, but all vaccines. And it is very important to have a conversation to stop misinformation, because what all this does is really erode public trust. Again, we'll be working with local partners from the communities that can also help educate persons from the community and families. And there'll be different methods used. Social media, in fact, many people now get information through social media. So certainly to engage also state and local health officials who really are already on board. Everybody is being prepared and getting ready to certainly be ready for the rollout of COVID-19 vaccines when they do become licensed. So I could go on and on about this, but I'm going to stop here. I tried to highlight some of the issues that we may face, but we know we have to educate. We know we have to earn the trust of the public. And I can tell you that unlike no other vaccine, this is happening. So thank you for this opportunity.
Well, Dr. Whitley Williams, our thanks to you. That was really important what you just covered. Boy, the chat function is on fire. The questions are coming in. We've got a lot to cover. We have some questions, plenty of questions that were sent in, and we also tried to get to some of the things that just people have been putting up now. What I'll try to do is, in the interest of time, combine some questions, because we have dozens of questions out there. And I'm going to ask our panelists to try to be brief so we can cover as many questions as we can. So I think the first thing is that if Dr. Messonnier and Dr. Marks, if you'll turn on your video so we can all get on this, and feel free to just help each other out here, answer any questions. But I'm going to start with a question for Dr. Marks. This came in from Bridge Green, who's a teacher and a member of the New York State United Teachers, Port Washington, New York Teachers Association. Bridge asks, since it normally takes years for these kinds of vaccines to be developed, how do we know that they didn't cut corners to rush them through the process?
So thanks. It's a great question. Much of what was done to save time here was to do certain things that would normally be done one after another, doing them at the same time. And the key thing here was that most of the time one waits for the kind of till you know you've got a vaccine that's going to work before you start to scale up the manufacturing process. And instead, while these large phase 3 clinical trials were going on, the manufacturing was being scaled up so that there will be plenty of vaccine available within the next few months. The part that is a little shorter here that it will be taken care of by following people over time is the follow-up over the longer term. Normally we would have 6 or 12 or 8 months of follow-up before a license application was submitted. And the way we'll deal with that is the Centers for Disease Control and FDA will work together to follow people who are receiving the vaccine, and the manufacturers will be following people who are in the clinical trials for longer periods of time. But our job here is to make sure at FDA that corners were not cut.
Great, thank you. And so here's one for both Dr. Marks and Dr. Whitley Williams, sent in by Janine, who's an administrative analyst with a member of AFSCME Local 1902. And Janine's read that all the vaccines in current development have yet to be peer reviewed. So if they don't make the cut, what happens to them? And along those same lines, there are places like Russia and Korea that have been just as far along in development. And then just a few weeks ago, some of these vaccines weren't deemed to be safe and effective once they were were reviewed, how are we different than that? What's going to happen to the vaccines that are not found to be effective or safe?
Well, I can start by saying that there is a very significant difference between some of these vaccines that are being studied in the United States and in Western Europe together, and in South America than perhaps some of the ones we've heard that might have been studied in China and Russia. That is that these are trials that are being studied in just the same way that we would study a vaccine for the flu or a new vaccine for pneumonia. They've been studied in tens of thousands of people, and that gives us a fair amount of reassurance that when we see the results of these trials, they will be believable. And so I think we're feeling that there's a reasonable degree of confidence. Now, I would not doubt that as we see other vaccines coming down the pike that are in development in the United States, we may see some that aren't going to make the cut. And that's our job at FDA, is to make sure that if they don't measure up, they don't get approved.
Okay.
Thank you. And I'd also like to just add, certainly we were hearing from our membership that there were concerns by the physicians themselves, African-American physicians, concerned about the safety of these COVID-19 vaccines. And this was very concerning because obviously their constituents, their patients are from communities of color. And what we did was to actually continue to put on webinars and actually have spoken with the pharmaceutical companies. We're participating at the CDC in the advisory committee to make sure that the information is flowing. Obviously, once the vaccine is licensed, that information will come to the ACIP. And again, we'll have another opportunity to really discuss the safety issues of any vaccine that's licensed. So there are many pieces in place to ensure safety. And then perhaps, I don't know, Dr. Masoni, if you want to talk about the safety pieces that are in place. There are many different mechanisms that are already in place and new ones that were designed specifically to monitor safety of the COVID-19 vaccines.
Yeah, thanks. Maybe just in the interest of being brief, because I know there are a lot of questions. I mean, if there's one message I would love for everyone listening to this to understand is how seriously we take the task at hand, which is ensuring that a vaccine is going to be safe and effective before it's rolled out to the American people. And frankly, if we had to compromise on one of those things, it would not be safety. And so we have an incredibly robust pre-authorization review of safety data. But as Dr. Mark said, for any vaccine, and this is not specific for COVID vaccine, we never stop studying vaccine safety. So we have well exercised and used systems. We've looked across the whole US government at the safety systems and identified a few places where we thought there were gaps or where we could strengthen things, and then basically added on additional systems. We want this to be one thing that you don't question, that we are going to have safety reviews consistently, and that this is a place where we're going to hold ourselves to incredibly high standards.
Right. Well, thank all three of you for that. So safety goes beyond just the individual taking the vaccine.
Oh, yes.
Marjorie Patterson, who's a secretary in AFSCME 2227, would like to take the vaccine, and she's eligible for it as a worker in an essential industry, she thinks, but would like to know if taking the vaccine will make it safer for her to be around her 80-year-old mother and her disabled husband.
Mm-hmm.
So I think what she may be asking is about herd immunity. That is, there's two ways in which vaccines are protective. They can protect you as the individual from getting sick, but some vaccines also protect you from transmitting the disease to others, basically giving an additional effect of the vaccine. And certainly we're hopeful that these vaccines will not only protect individuals, but also protect you from transmitting. But frankly, we don't know yet. And so I would tell anybody who's getting the vaccine that at least in the short term, until we can continue to study those things, you actually still will need to practice precautions, wear a mask, keep your distance. You certainly don't want to be infecting somebody else. I know everyone's been working so hard this year to keep precautions in place. And unfortunately, on day one of rolling out the vaccine, we won't know enough to say that we can all rip off our masks and, hug our neighbors. We're going to have to keep with those precautions, at least for the time being.
No, that's right. So actually, let me jump to the questions that are coming in here, because that really led to one. Here's that was a question from a secretary, probably in a healthcare institution. So what is a healthcare worker? The various panels have said healthcare workers will be prioritized. But as everybody on this call knows, there are many people who are healthcare workers who aren't physicians or nurses. And how will they be included in this? Because they're certainly exposed. And we know in nursing homes, thousands have been sickened.
I think I get to start on this one, and I completely agree with you. The term healthcare worker includes paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. So it is a broad category. Our advisory committee on immunization practices also recognized that in these early days of rollout of vaccine, there may not be enough vaccine for every healthcare worker. So they have given additional considerations for sub-prioritization. Basically, if there aren't enough doses on the very first week for every healthcare worker, how is a jurisdiction or a healthcare system going to decide? And in general, they have three categories of equal importance: healthcare workers with direct patient contact who are unable to telework, healthcare workers who are working in residential care or long-term care facilities, and then healthcare workers with documented SARS in the preceding 90 days may actually choose to delay their vaccination because there is current evidence that really suggests that if you were recently infected, you probably aren't at risk, at least in the short term. So some of those healthcare workers may actually decide to get at the back of the line.
Okay, and let me follow up with a question here that was sent in by Mallory Hagel, who's the Care Provider Division Director at SEIU Local 503. So it really follows up on that. So who's making the decision on who's eligible for early vaccines at the state level and the federal level? And who's responsible for deciding what you just talked about, what qualifies as a frontline healthcare worker or a first responder? Who's going to make that decision?
So I'm going to start by saying, I am really excited that these vaccines are rolling out. And I think it's been a really long year for all of us, especially I know for healthcare workers and essential workers who have been on the front lines and putting themselves at risk and really not able to hunker down at home. So I just want to offer my respect for the work that you do and are continuing to do. There's a light at the end of the tunnel, we think, with this vaccine, but the tunnel may be a little long. It is unfortunate, but just the reality that in the early days, there may not be enough vaccine. I'm really hoping that we get through this initial stage quickly. The way that this is working is that vaccine is being divided by population size pro rata to the health departments. And then CDC is working with the health departments to put together their plans. Our recommendations to the health departments is that they have a very inclusive process so that all the stakeholders are around the table and part of the decision making. But I know that in the early days, there are going to be some hard choices. They're working with their healthcare systems. They're trying to come up with, I think, equitable approaches to this, but it is exceedingly complicated to sort of figure out who gets first in line. And I just have to ask you all to be a little patient. I know that they're working hard to try to sort this out. And frankly, some folks might not like the conclusions that they come to, but they're operating in good faith based on the data that they have and trying to make good decisions.
Great, thanks. So we've received a bunch of questions about equity and distribution, which you've just referred to, and how we're going to reach out to communities and people of color and the prioritization of groups of people who should receive the vaccines. So here's a question from Katie Dunn with SEIU 32BJ. how are you planning to do outreach to Black, Indigenous, and people of color communities and address their valid concerns about structural racism? And a similar question came from Nicholas Marcelletti, who's a part-time faculty member of the AFT at Manhattan Community College. How are we going to make vaccine distribution as fair as possible?
So that's
You're muted, Dr. Whitley Williams. Thank you.
I'm very sorry. Actually, that's an excellent question. I actually serve on the New Jersey State Department of Health Professional Advisory Committee that has been meeting at least twice a week for the last several months. And as was just discussed, a plan was submitted to the CDC as required for all states. And it did, I have to say, is pretty close to what was recommended by the ACIP just the other day. Actually it was yesterday. Did I go off? Okay. So I would say that we have been working, when I say we, the National Medical Association has been working very hard to educate its providers who predominantly work in communities of color, also through webinars and so forth, to engage people who are not in the healthcare system, to talk about the COVID-19 vaccines and what are the risks, or at least we've also tried to encourage people of color to engage in the clinical trials. And this is, I know, something that's been a barrier in the past, but what we're finding is the more and more education that goes out there about not just COVID-19 vaccines, but all vaccines, that this is important. There is definitely a disproportionate effect of COVID-19 on persons in the community. I understand that there is underlying systemic racism, but I can tell you that there is full representation at the state levels, and we are certainly dealing with the issues of equity. I think what we even looked at numbers and breakdown by ethnicity in terms of healthcare workers, paid and unpaid. All the health systems are represented on our committee, and this is very similar to what other states are doing. We actually will have an effect in terms of being able to offer a vaccine to people who live in communities of color, because either they work in long-term care facilities, or they are essential workers, or they are healthcare workers, paid and unpaid. So there is some crossover. Yes, COVID has disproportionately affected the Black community. However, to come out, I think, and offer the vaccine to that group only, really would, I think, at least on our state level, would have caused some major problems. But definitely, there has been much discussion about it, and people of color will be included in that first round.
Great, thank you. So we got some questions on a topic that no one's touched on yet, which is this employer vaccination clinics, because they're out there right now. A lot of people work for institutions which have seasonal flu clinics, for example, for employees. So Scott Seimer, who's a library assistant 2, member of AFSCME 1546, asked if COVID vaccinations will be employer coordinated like those flu clinics, or will there be a different distribution system depending on insurer and will be based on the county or the state? And Geraldine Stella, who's the director of health and safety at the New York State Public Employees Federation Local 4053, asked if employers conducting worksite vaccination programs will be required to offer training and informed consent. And is there sort of an ideal worksite vaccination program, the model that we could look at or suggest that our employers use?
I think that probably starts with me. I am a huge fan of worksite flu immunization clinics. Actually, I can tell you that people who work in places where there are on-site flu vaccination clinics have higher vaccination rates than people that don't. So it's something that we encourage. This year, though, frankly, with so many people teleworking, some of those programs that set up to do on-site flu vaccination had to really modify what they were doing to do other approaches, for example, drive-by vaccination. I would think of this vaccine rollout in a couple different stages. So in this initial stage, with limited supply of vaccine, we have to really tightly control the administration sites. Also, frankly, these early 2 vaccines have some complications in terms of how they're stored and delivered. The first vaccine, the Pfizer vaccine, requires storage at ultra low cold temperatures, and your regular doctor's office just doesn't have that temperature freezer. And the Moderna vaccine also is a little complicated. And so for those vaccines, there are some specific operational realities of trying to figure out how best to make it work. As we move into the spring, we really hope that we're going to go from limited supplies of vaccine to larger quantities of vaccine, frankly, enough for anyone, based on what we're hearing from Operation Warp Speed. And I think it's at that stage where we're really going to need to take advantage of every possible place where you can vaccinate, because frankly, that's the best way to get everybody vaccinated really quickly. That may involve, in some places, on-site vaccination clinics, but we're really asking the health departments to figure out the most efficient way to get a lot of people vaccinated really quickly, and to make sure that they're taking into account social determinants of health in communities that don't have easy access to vaccine, by making basically the vaccine more easily accessible to them. So I think when we get to that phase, there'll be a lot more stand-up vaccination clinics. Now, the one caveat is that some of these groups of essential workers that are sort of kind of actually coming up early next year, the best way to vaccinate some of those essential workers may indeed be at the workplace, basically scheduling people so you don't have people congregating, but really getting people when they're coming into work. Most health departments haven't completely planned out that phase yet. I think as soon as we start rolling out this initial vaccine, there will be a lot more attention to planning for that.
And if I could just add here, obviously all of you are union members. Your unions have collective bargaining agreements with your employers, and this is something you should be stepping into right now and beginning to raise discussions about how this can be done, because you have a role to play in this, and you want to make sure it's shaped in a way that really works for you. So here's a question from Louise. Oh, actually, let me follow up on one more that really relates to something Dr. Messonnier just has talked about, something that's come across in the chat room here. Will this be free? Who's going to pay for these vaccines?
Yes, the vaccines should be free, not just the vaccine itself, but the administration's fee. So vaccines kind of come with 2 costs. There's paying for the vaccine itself, and the US government has purchased these vaccines upfront, so there's no cost. But in addition, there have been provisions in place to ensure that the administration fee is covered. And for people that don't have health insurance, there's a mechanism in place to ensure that they can get the vaccine free of charge and no copays.
That's great, thank you. So Louise Curran, who's president of AFT Oregon Retirees, 8035R, and I think we have to be thinking about union retirees and all retirees. So she writes, as president of a retiree chapter, I'd like to know how seniors will find out how they're being prioritized for vaccination.
Boy, that is a great question. And I wish I could give you a completely straightforward answer. In the early days, there is going to be some differences from state to state, from jurisdiction to jurisdiction. And so really the best way for you to figure out where you are in the priority list with great precision is to go to that same health department website, which is, I presume, where everyone's been going to check on the disease risk in their area. They should have the most precise information specifically about where you fit. Again, early days, limited quantity of vaccine. I really hope that phase will be short. But in that phase, you can basically definitely work through the health department. For folks that are workers, I would also hope that you could work through your, I guess it's the unions and your work organizations, because I think a lot of that discussion about sort of how to prioritize the essential workers and how that's going to work in different parts of the country, that's a slightly different conversation. And I really hope that that can sort of be a little bit more for occupational group. For healthcare workers, I really hope that you're already having these conversations with your own healthcare system, because as Dr. Whitley Williams said, in most jurisdictions, this is actually, the planning is actually quite advanced. And so if you haven't heard anything, if you're a long-term care facility worker, if you're a healthcare worker, you should be getting in touch with your employer and making sure that you understand what their plans are.
Boy, thank you. This has been a really fascinating and amazing conversation. And the question list and the chat room are both just filled up with questions. We're not going to be able to get to all of them, but I want to end with one, I think, question that all of us would like to know the answer to. Just today, President Obama was asked about the vaccine. And what he said to a reporter was, he said, people like Anthony Fauci, who I know and I've worked with, I trust completely. So President Obama was asked, are you going to take the vaccine? So he said, if Anthony Fauci tells me this vaccine is safe, that I can get immunized from getting COVID, absolutely, I'm going to take it. So I want to ask our three experts here, when your turn comes, when you're prioritized, will you and your family members get vaccinated? So let's start with Dr. Whitley Williams.
So I would agree with former President Obama. If Dr. Fauci says it's safe to take, I certainly will take it. I also have a colleague who's also a pediatric infectious disease specialist who's on VRPAC, which is a committee that will make a recommendation to the FDA whether to license a vaccine. And if he says to take it, I will take it. I'm African American, I'm over 65 years of age, I have obesity, I have asthma, I don't have diabetes. I will take the vaccine if it's licensed, which means that it's safe.
Okay, Dr. Messonnier?
Yeah, the answer is unequivocally yes. I trust the systems that we have in place. I trust the Data Safety Monitoring Board. I trust FDA's VRPAC and my FDA colleagues, and I trust ACIP and the scientists at CDC. If the vaccine is authorized by FDA and recommended by ACIP and it's my turn, I will be there with my sleeve rolled up. And frankly, the same is true for my parents and my husband and my children. When it's our turn, we will be there with our sleeves rolled up, ready to get that vaccine.
And I want to end this with Dr. Marks, because he is the man in charge of really making this decision first for the country, as well as for his family and for himself.
Thank you. So I mean, unequivocally, if we decide that we can authorize or approve a vaccine, it's only going to be because we're willing to be at the head of the line. If we could be at the head of the line to get the vaccine in our own arm and to have our own families be there with us. And I can assure you that we have a very large contingent of people working through looking at these vaccines to make sure that they are safe and effective. And they do so with the standard in mind that they want them to be safe and effective for themselves and for their families and for all of us. So I won't have any problem whenever it's the time. My sleeve will be rolled up.
Great. That's a great point to end on. We could go for hours. There's so much to say. This is the beginning of a conversation. The whole country is having this conversation now, and I think you certainly are going to be a very important part of it. Your unions, the people you represent, need to hear from you what you've learned, and we've got to move this forward because we have to stop this pandemic. So first, join me in thanking the three panelists today, both for joining us tonight, but also for their really tireless work fighting this pandemic. They're heroes, and I'm very grateful. I think I speak for all the country, thanking them for their work. If we could applaud right now, I would. And I want to thank the three unions for doing this, and for all of you for taking time out of your schedule to join us tonight. And forward, hopefully things will get better. We'll use this vaccine, and we'll be able to get the country working again for everyone this time. Good night.
Thank you very much. Take care.